And last but certainly not least, we have the pleasure of hearing from Cecilia Pompili, who is Associate Professor at the University of Hull, and she's going to be telling us about something that's essential, which is putting patients at the center of lung cancer care. Cecilia, the floor is yours.
And of course, a special thank to Deborah and all the Luce committee, because it's a very great honor for me. I will follow this amazing presentation from a clinician standpoint, so I will try to give you a little bit of background on how I'm trying to convince my colleagues, especially surgeons, that patient-reported outcomes and patient input in clinical care, but also in research, are so essential. So you can see also from my titles that I'm a thoracic surgeon, but my academic side is focusing on patient-reported outcomes, so that's why the title is in psychosocial oncology. And it's very crucial because without data and without the these are my disclosure, without the real impact that your voices and your feedback from care are impacting, of course, on treatment. So I'll give you a little bit of data, so hopefully I will not bother you too much with graphs, but again, just we know, of course, that the treatment impact has this threefold aspect that we are all following, and we heard from the first presentation, of course, the third one. So we are always following in the main clinical presentation those that are disease-free survival and all the clinical outcomes, and then there are the patient-reported ones. I want to highlight that even the economical aspect, you have also now the patient experience data, and we are working even in surgery to implement patient experience feedback into regulatory approvals. So I think these are very, very important. And again, the outline will give you a little bit of data on what has been done and why we really need those outcomes reported in all the studies or trials, but also in our conferences, the importance of your experience of care, of treatment, and as Elisabetta was saying, the psychological impact of treatment on patients. And we've seen that, for example, HESMO has already implemented quality of life assessment in the clinical benefit scale. Again, without going too much in details, it's just that quality of life, his grade is, part of the grading to have a benefit when they are evaluating treatment. But unfortunately, this is a recent review. When you are looking at the probability of inclusion of quality of life into so big trials, you can see that unfortunately, lung cancer is the one that is reducing the amount of clinical patient-reported outcomes data reported. And this is a review that we've done recently. You can see there, close to the scalpel icon. So essentially, these are, you probably know all of these famous and remarkable trials, but essentially, quality of life assessment is missing up to, let's say, up to surgical treatment period, but most importantly also after treatment. So if the patient is not starting the adjuvant, the patient will not fill any quality of life questionnaire, which means that we are missing almost 3 months of assessment during the perioperative care. And I like to put this one, so I have the fortune to do this quality of life research since few years, and this is the first slide that I was building I would say more than 17 years ago, but I really think that is so important. So this is the patient's major concern, maybe not the perioperative morbidity or mortality or what we call the percentage, but rather to not be able to resume the acceptable, so the tailored daily lifestyle. So we've done this one in this survey in 2015, and as you can see, less than 50% of surgeons of the ESTS were collecting any kind of quality of life data. So we repeated this last year, and as you can see, even with the Japanese Association of Chest Surgery, essentially the situation is exactly the same. So more or less 50% of the surgeons are collecting any type of quality of life data. And this is also a little bit surprising because in Japan they have this big hub for clinical trial research, but even then they are not collecting routinely quality of life data. So a little bit disappointing, but it's important to publish this, especially in this journal, surgical journal, to highlight the importance of, as you said before, to actionable point. And now I will give you, again, few examples on how we publish on the importance of quality of life in our journey, because we've done this one, which is the prognostic value of the pre-operative quality of life on survival. So we've done several studies on this, and this is with one questionnaire that is the RTC C30. But then quality of life was also a predictor of post-operative complication. So there are some patient-reported factors that are very important to define patients' fitness, for example, that are not captured by the usual, let's say, pulmonary function test or clinical outcome. And with Georgia, we recently published, so she led the new ERS, ESTS guidelines for fitness for radical treatment, and patient-reported outcomes were definitely missing. So we had some of the evidence to implement quality of life, and again, some aspects reported by you, by the patients, that are not captured from what has been done so far. We have, we will talk about the AI. I think is a good option also for limiting the burden to collect all this data, especially if you're talking about clinical practice. We try to do this in lead with the electronic completion. EPROMs are the collection of quality of life online, and you can see these are the electronic patient record, so the doctor can see how the physical function or the symptoms can change over time, and this was also helping to define. So all this line, you can see the difference between surgery or SBRT, so radiotherapy, and it's important because this is also helping the discussion when the patient is borderline, and we need to have a shared decision making, because a lot of patients are still asking how will be my quality of life, how would be my life after radiotherapy or after surgery. So those are very important information, and those are all, again, some data. I will go a little bit faster here because all those trials have reported quality of life, but those are, as I've seen, you've seen in the first slide, so essentially those reporting are either in the appendices or not reported well in the main manuscript. So Adora was doing the same. The Checkmate 816 was reporting differences after surgery, but not a lot of good reporting of this data that we can discuss in clinic and with the patient. So I think this is also important when we look at the reason why the patients are not completing, for example, neoadjuvant or adjuvant treatment with immunotherapy or extra. So here you can see that in some of those trials, there are some reasons that are not well defined, and this is another battle that I'm trying to do also with pharma in terms of being more precise when we are collecting those data, why the patient is stopping that treatment and not just withdrawal by patient without a clear reason. So we need more information, we need more granular data, because with quality of life we've been able, for example, to stratify patient and have high risk patient before surgery, and we were able, for example, to refer patient for prehabilitation before surgery. So prehabilitation, now we have this gap during the immunotherapy before surgery, so we cannot complain as surgeon anymore that we need to operate immediately, so we have more time. So there is an option through quality of life, for example, screening tool, to have hybrid short-term prehabilitation during neoadjuvant or after. We will start this in Hull very soon. It's a charity-funded project, essentially giving exercise intervention and granular quality of life assessment to implement prehabilitation during neoadjuvant, and understanding how quality of life aspect will potentially give screening tools to identify more patients for prehabilitation. And again, just a touch on the instrument. I'm sure that you probably have filled some of this questionnaire. There are a lot of long questionnaire. We are working, I'm part of the OTC Quality of Life group, and we are working on the item library approach because these are definitely too long questionnaire to fill. There is a strong, let's say, again, another battle with the methodologists that are still keeping the C30, that is the 30 questionnaire. But as clinician, I think we really need more tailored and pragmatic approach. That was the work that we've done for the lung cancer module. And for the first time, we introduced the surgical specific questions. And this is the approach that we would like to have. So the treatment plan is evolving a lot, so we need to approach that in different ways. So immunotherapy related question when you are receiving immunotherapy, surgical related question if you are receiving surgery. So also this is another slide that I'm always stealing from Jill, but with her permission, of course, because I think the concept of tolerability is something that from a clinician is really, really hard to still report and introduce in trials. So it's different from surgical complication, it's different from toxicity. We still need to have those tolerability reports. And that was an example in terms of side effect perceived by the patient. So the Libretto and the Cocoon trial, they implemented as a secondary outcome quality of life and tolerability as endpoint. That can be a way forward. And not sure it's not moving. Oh yes, sorry. So sorry. And again, this is just to explore how, however, it's difficult so far to assess this toxicity for immunotherapy. And you can see that not a lot of standardization is present. So we have still the OTC Quality of Life questionnaire that when this paper was done, they were not releasing yet the immunotherapy items. So they are just recently available in the library. So we need more standardization on these, but they're so important. And I don't need to mention, of course, these other aspects of quality of life that are often overlooked and definitely not included in trials, but definitely we need to have a look at. So of course, the financial toxicity that you've done this amazing work in assessing, and I think it's very important to advertise this report. And I really like the idea of having national policy and report and potentially policy. I'm working again through the OTC a little bit more on the time toxicity because it's the other aspect that I would say not a lot of clinicians are aware. However, we need some metrics to potentially have a comparable strategy in trials, and I will say even in clinical practice. So just to conclude, I think it's important in terms of how do we enhance with all this data patient and healthcare communication. We've done this qualitative study, and I was impressed. That was a few years ago. But still, that was about how the patients were perceiving the quality of life collection, because we're always saying, oh no, the patient doesn't want to fill the questionnaire. But in reality, they were reporting, and I will leave those quotes here, that they were even the collection was helping the patient to discuss with the surgeons. And again, unfortunately, I'm negatively biased by my subspecialty in terms of surgeons are not the most well-trained in terms of communication, but the patient was just filling the questionnaire, feeling that they were able to discuss some of the aspects that nobody was asking them directly. And there is a lot of on the women's side that I'm happy to discuss you in a separate way or during the coffee break, because some of the symptoms that are definitely only for women were never touched or never discussed. So it's very, very important, and I'm very glad that through those research with Yvonne, I can't see, yes, she's there. So we are doing this amazing work. So we finished now the interview in terms also on focusing on the gender type of research, because again, that was coming from the qualitative study, but we found that it's very different to approach after surgery these new demographics that are emerging, so more young women diagnosed with lung cancer, and also early stages that are coming through our clinic and we were not used before. So we really need to understand the patient preferences and the diagnostic gaps and delays, unfortunately, in this sector, and specific need for young women, for example, with working experience, active experience, and of course, childcare responsibility. So this is a very important one, and we try to also raise awareness with the hair-lung study at the national level, because it is still very, very difficult. I will be quick. So this gender type of medicine is also in our lung resection. We've done this review, and essentially we discovered that in the surgical setting, the women were reporting lower scores in mental health after surgery, and in general, unfortunately, those studies were not reporting differences between genders. So we really need more gender-specific data, again, not only in trials, but also in clinical studies. And we found only 5 out of these 11 studies reporting the breakdown of gender-specific quality of life. And this is also, of course, interfering with shared decision-making. So that was another study that we've done. It was more about surgical, so early stage patients that were discussing about surgery versus radiotherapy, and we found essentially that nobody was offered the second option, or especially when the patient was borderline. So if the patient was referred directly to the surgeon was not offering, oh, you have these other possibilities, so do you want to explore? And this was reflected in the patient confidence. So to conclude, so I think this is a huge background to say that we really need you. We really need the patient advocates also in thoracic surgery, so in all the continuum. So we've done this work with all these fantastic people of Luce, and I'm very glad that this has been published again in a thoracic surgical journal, because this is where the surgeons will be accessing those important information, and we try to explore and to give them all the information about patient advocacy in Europe in general, and how the comprehensive patient advocacy can also reduce this inequity in care in general in surgery. We've done more in general, so even in palliative care and in patient participation in lung cancer surgical treatment in this cross-cultural collaboration with US as well. But again, I think that optimizing the treatment plan will never be successful if we are not integrating patient voice in an holistic way. And this is also to strengthen the multidisciplinary collaboration between clinicians, because I think as a surgeons, we are not used as anymore as oncologists to involve patient, but we are now part of this multidisciplinary long-term plan. And so, as Deborah asked me to touch, the patient is definitely at the center of our care, but we need to link with compassion and communication and respect all this dot together. Thank you, and apologize for this.